Good afternoon. Hello, everyone. My name is David Knowles. I'm the Managing Director of the Kenan Institute of Private Enterprise here at Kenan-Flagler, and it is my pleasure to introduce today's Lunchtime Keynote program, which is part of the Kenan-Flagler Dean Speaker Series, which is made possible through the generous support of the Archie K. Davis Endowment. And this series was created in 1983 to bring outstanding scholars and leaders from business, education, and government to share thoughts and insights with UNC Kenan-Flagler, the university, and the wider community. Today's fireside chat will be moderated by Kenan-Flagler Dean Mary Margaret Frank, Alumni Distinguished Professor of Accounting. And so a brief introduction for Kevin Kettler, who was our distinguished guest today. Kevin is Executive Vice President, President of Prescription Technology Solutions for McKesson Corporation. As a member of the executive operating team, Kevin is responsible for providing leadership and strategic direction for the company's CoverMyMeds business. CoverMyMeds works across the healthcare delivery system to connect pharmacies, providers, health plans, and biopharmaceutical companies with next-generation medications and access, adherence, and affordability solutions that help get the medicines they need to live healthier lives. He joined McKesson in 2005 and has held a variety of leadership roles at the company, most recently as president of McKesson International. Kevin was responsible for leading the company's businesses in 13 European countries and non-US based drug distribution services, specialty pharmacy, retail, and infusion care services. Kevin's tenure at McKesson also includes serving as president of McKesson's Global Procurement and Sourcing based in London. He holds a Bachelor of Science in Mechanical Engineering from Notre Dame, and we are quite proud of the fact that he also has a Master's of Business from Kenan-Flagler Business School. So with that, please join me in welcoming Dean Frank and Kevin Kettler.
So thank you for being here. Can you all, everybody hear me? Okay, thank you. I really appreciate the thumbs up in the back. That is a very helpful signal. I got it. So I want to add one thing to the introduction. So one of the things that we talk about here is that, there is a positive power of business, and I think about the positive power of business that in the healthcare space. But there's a caveat there. The powerful positive business when led by the right people. And I am thrilled that you have the chance to hear from Kevin Kettler, who I've known for a really long time. And I can say without a doubt that healthcare is being led by the right people when you have Kevin in the room. So I want to thank you for being here. Appreciate it.
Well, and I'll return the favor to say I couldn't be more excited to have this organization as you as their Dean, Mary Margaret, for exactly the same reason. So you should all be very appreciative, and you're incredibly lucky to have somebody of great quality leading this as Mary Margaret.
I appreciate that. Okay, let's turn to healthcare. And let's turn to healthcare and the intersection. Healthcare it helps and serves people, but it is a business. And when we think about businesses, at least I do, I think about markets. Right? And we think about markets, the concept of market. Let's think about all the different markets. Stock market, labor market, commodities market. Right? Those are all different types of markets. And when we think about markets, we think about supply and demand, right? And so when we think about supply and demand, we think about price, i.e. cost, right? So as you think about the healthcare space, that market is not like some of the other markets, right? How do you think about the healthcare market?
I think the healthcare market is different. Can I use the word screwed? No, I don't.
No.
So the healthcare market is incredibly complex. I think if you think about the fundamentals of what make all the things we learn about in terms of efficient markets, it's the ability for connectivity of information, of decision-making based on price versus value. It's a decision-making that's based on understanding what the value is at the time that you make a purchase. All of these things are disconnected in healthcare, right? If you think about when you go to get your car serviced. You're going to go get an estimate and make a determination on whether or not it's worth, $1,000 to replace your tires or $800 to fix your front brakes or whatever. Now, take that same analogy and say, what happens if you decide you're going to go get a medical procedure? Well, first, you're not sure where to go because you have no information about the quality of the provider that you're choosing. So there's a lack of information. There's absolutely no transparency on when you walk in, if you're going to get that procedure, how much it's going to cost, or who maybe even is going to be the deliverer of the service. And so now you've got no information and transparency about the quality. You've got minimal information about the cost. Maybe you know your copay, but the copay for a component, but then you may get another service bill later. The timing on which you have that information can be a week or two or a month later. And so you go through all these machinations and you're like, how can you actually make the decisions that drive kind of normal functioning markets? Now, I will say it's getting better, kind of. But if you take the macro view of what goes on in healthcare, the last thing you do is most of it you don't pay for. So while we do have increasing out-of-pockets pretty much for all of us, the reality is, take Medicaid or even Medicare or employer-based insurance. My employee pays for about 80% of what happens to me. And so do I care? Yeah, I care about 20%-ish of the total value of what happens because it's my money. Actually, I probably care 100% about my money, but it's only 20% of what I'm committing to. And so all of these disconnections of transparency, of quality, of discontinuity of the individual making the decision to what it actually has to cost me in order to make that decision, I think are the fundamentals that build impediments for this market to kind of work right in kind of how things function.
Well, when you think about markets and you think about the challenges in the supply side, right? So markets, there's supply and demand. On the supply side, what that really is about is, to some degree, the access and the impediments to how do you get the product out there, right? And so, if you think about the things that are happening right now, I do continue to watch the news, right, periodically, in the sense of, we have tariffs coming out, we have manufacturing being moved back to the U.S., investments. There's this thing called most favored nations policies that, right, there's all this stuff happening in the healthcare industry that potentially affects access. And so how does that then affect the markets and what we see in reality?
There's a lot in that one. So let me start with, you talked about most favored nations, and tariffs are very closely related. And then I'll just say the role of the government in terms of trying to determine the price of drugs. So I'm going to introduce a couple of people throughout the day. The first one is a guy by the name of Paul. So this is a guy I worked with out of Kenan-Flagler. He's one of my first guys. Sat next to me in a cube at McKesson 21 years ago. And Paul told me on my first day, Paul's a Stanford undergrad, Stanford grad, Harvard law guy. So he's this dumb kid sitting next to me, and because he didn't choose to come here. And
Right
what he says to me is, he's like, we're screwed. The price of drugs is way too high. The price of healthcare, it's 16% of GDP. It is $2 trillion, right? This is 2003, 2004. Like there is absolutely no way that we are going to have success as a country. We're going to have this horrific kind of life-changing cost event that's going to be inflicted on healthcare. Well, I would argue Paul probably wouldn't, but that he wasn't right, right? We have now seen healthcare spending grow. I think it's about 5.5, 6 trillion. There were some analytics. Where's Andrew? So I think it's 5.5, 6 trillion, 18-ish% of GDP. So we have continued to see the cost of healthcare continue to skyrocket, right? And it's partly because of the dynamics we just talked about of not having a healthy market, partly because of innovation and growth. I'm sure we'll talk about that. But I think what that's done is put pressure on the healthcare system like we haven't seen before. So I'm getting to your question. I'll get there. I promise. We'll get there eventually. So one of those pressures comes from what you're talking about around MFN, and I would loop in the most favored nation. Sorry, thank you. MFN. Yeah, I'll throw on. I'll see how many acronyms I can weave in here as well. IRA, so the Inflation Reduction Act.
Oh, not the other IRA.
Not the other IRA. Not where all your money is. The Inflation Reduction Act actually has government now acting in the role of negotiating prices on behalf of Medicare Part D constituents. So this is a new act that is coming into effect on January 1. The One Big Beautiful Bill and the cuts of about $1 trillion in Medicaid funding. So all of these things are basically price pressures on the system that are meant to go back to how do you actually balance the cost of, most of that is medication, although Medicare is broader, against, so it's basically constraining supply, right? So it's so now burdensome on the organization. So maybe Paul's now right, maybe, that all of these actions have now come into place. So if I think about, I'll deconstruct a couple of them, maybe MFN. So that's a pretty interesting one because if you look at what's gone on, I would say how manufacturers approach MFN is manufacturer specific. And broadly, I would call them kind of GLP-1s. Do you know what GLP-1s are?
I don't, so I'll admit it. Okay.
Kardashians, Ozempic, so I'm trying to relate it to something my kids. They're essentially weight loss and diabetic drugs. They're on fire right now. They're the biggest thing. So there's kind of a category that just got announced as it relates to the government. Now, Trump is kind of using his, what some might call a bully pulpit to influence, not through legislation, but through pressure to say, hey, we expect the U.S. government to be, as the biggest consumer of drugs, to be the most advantaged when it comes to the price of drugs. Seems pretty reasonable, right? Most favored nations is MFN means we got the same price, or better, actually, given the volume. And so how that's expressed itself, or how people have adjusted to that, is I'll talk about two categories. So one is non-GLP-1. And I think you've seen, so Pfizer struck a deal, a few others have struck deals that said, we're going to bring back manufacturing, which is what the administration wants. In return, we're going to lower our prices. And each one is going to have each manufacturer is going to have a slightly different math, right? So do I have a lot of Medicaid? Do I have a lot of Medicare? Is it a high-priced drug? Is it a low-priced drug? So each one is kind of going in and striking a deal to give a little bit, or maybe give optically a little bit, depending on the manufacturer. And in return, make some commitments around manufacturing in the U.S. So they've solved the manufacturing in the U.S. They've solved the administration's desire to lower rates. And by the way, they are, in some cases, raising prices in other parts of the country. So that's everybody but GLP-1s. And I would say the only difference on GLP-1s, I think the Novo Nordisk gentleman was here earlier, I don't know if he's still here, was I think they've done an interesting job of, they're really doing price for value, so, or price for volume. So they actually have said, you want weight loss drugs. Weight loss today is not covered by the government, at least not on Medicare plans. And they said, I tell you what, you consider accelerating our orals. So there's an oral treatment for GLP-1 for weight loss, and add it to Medicare. So for older Americans, we will drop the price for the government. And so the government price went down. So now they get expansion in terms of the coverage from the government, and in return, they give discounts back to the government. Government's banking on the fact that these will bring healthier people through medication, and they'll save cost, and they're reinvesting that cost in treatment of additional services, and the GLP-1 manufacturers then are going to see volume upside. So that's the things going on.
So interesting, because that's, I mean, to some degree, that is a partnership in the sense that you're negotiating almost like an individual contract with the government, right? And that's one way to affect access, therefore price, so affordability. There are also other types of partnerships. that companies can strike with other players, not just the government. Have you seen that in the industry, and has that been able to affect the affordability of drugs? Because that's a lot of what we hear about is the high cost of medication.
Yeah, so absolutely. So I think you hear about the high cost of medication because over time we've seen increases. Now, what, a $800 billion-ish market, depending on how you measure it in the U.S. I guess I'll go back to, let's talk commercial for a minute. So, I'm covered on a commercial plan. Most people here probably are. Most of you also have a card in your wallet for a pharmacy benefit manager, a PBM. And the role of the PBM for the last 25 years has been, how do I connect dots across usually employer bases, take the prescription activity and go get at volume, collect that volume to go get price reduction, right? And they usually do it by tiering, making choices about, we're going to go on what would be called a formulary, we're going to have a preferred element. In the case of GLP-1s, they may pick one Novo product over the Lilly product for a certain medication, as an example, and then they give incentive to the individual through a copay and say, well, we're going to make this one $25 and make this one $50. So the great thing is, I think for the U.S., that role of a PBM has served a lot of scaling and the ability to go negotiate on behalf of all of us. I think the skeptics would say that going back to the first market discussion, if you have a large-scale player, the ability to continue to iterate the model and capture more of the value versus pass some of that value down, I would say has been questioned, right? So that would probably be the nice way of saying it. The FTC investigation, if you go look at the FTC documentation a year ago, might go beyond questioned. But I would say they have been skeptics of some of the practices. So I think depending on which side of the aisle, we've actually benefited from having continued innovation through manufacturers continuing to bring drugs to market, but yet we're also incurring the cost of the innovation of those drugs when it comes to the affordability of new treatments, maybe offset a little bit by the role of the PBM.
It's interesting. This is completely, I was just, as you were talking, I was thinking about this. My husband is a doctor. And I watch him go through, he's a psychiatrist, so you can imagine. I watch him go through that. And there's the value, but there's also the efficacy. And, one of the things that I notice as he's going through this is what he has to do in thinking about when somebody's on a plan and their drug that's best suited for them is not on that plan, right? And so we're trying to control cost, but in controlling cost, are we giving up wisdom from the doctor? And how do you think, how does the industry think about that trade-off?
Oh, I'm not sure I can speak on behalf of the entire industry.
Yeah. Right. So, but it was,
But you're absolutely right. So I think one of the things that we try to do at CoverMyMeds, so we have a business called Prior Authorization Plus that really was the starting point for building a digital interaction for prior authorizations. Yeah. So you'll hear the term utilization management or prior authorizations, and what that is if you're covered under a health plan or a pharmacy benefit, what will happen is if I get prescribed a high-cost drug, my plan will be like, not so sure. Let's make sure that Kevin actually should go get that drug, right? Or even better, why don't we try Kevin on a cheap drug because it's 80% my money and only 20% his. Let's try him on a cheap drug first, and if that doesn't actually help him out, then we'll make Kevin jump through a bunch of hoops, which actually makes Mary Margaret's husband jump through a bunch of hoops to answer all the questions about it, and then we'll allow Kevin to get on the drug, right? So that's the kind of utilization management or prior authorization reality. Now that can happen for a medicine, it can happen for a procedure. So I think that's a reality in our healthcare system. Now, you could get rid of all those prior authorizations and wide open access, and I think you'd probably have a cost problem. So that's kind of it's a balance that we've created in the healthcare system that hopefully is kind of serving its purpose. So what we've done is tried to at least digitize the interaction. So I'm not sure I can speak to whether or not it should be that the doc should allow or not, but it shouldn't be that the doctor should have to go spend, the office hours, an hour and a half combing through medical records and fax information from the lab tests and, questionnaires to the patient, and then fill out, like 10 years ago, a piece of paper, fax it in, or pick up the phone and, like, you laugh. We still process 2 million faxes, right? And we're probably one of the most scaled, digitally enabled services in healthcare. We process 2 million faxes. So we've digitized that interaction through AI and use of contemporary tools, but that's the reality of how many constituents within healthcare operate today. And we've digitized those and allow, in our case, the payers, the PBMs, health plans that are making those determinations, allow them to consume them in a digital fashion to make the manual process a little bit better. So that's really the role we play in that, is trying to at least help speed the communication and ease the process burden of that reality.
So what I hear you saying is, given the structure that we now have, you're sort of the pipes. CoverMyMeds is the pipes. And as long as the pipes are working efficiently, the process should be more efficient. You're connecting the different players together. Is that?
Yeah.
Is that what you would say that CoverMyMeds does to help with affordability, or?
Yeah, that's probably more access.
Okay.
So if I were to shift maybe to like what we do on affordability, maybe back to the discussion on the role of the PBM and the role that we play there. So we talk about that prior authorization process as access, because you want access to the medication, but you don't get access because you got to go through this, burdensome process. But let's suppose you take that same pharmacy benefit card, you walk in, I was going to say Rite Aid, but you can't do that anymore. You walk into the local CVS and you present the card. What happens when you present that card is enabled by us as well. And let's take the example, you've got a $500 branded medication when you walk in, you hand them the card, you actually don't have any clue what it costs, because back to our point number one.
Yeah.
But when you do it, somebody does, right? And what happens is you hand that card to the pharmacy, they swipe it, and they run a transaction. And they basically check whether or not you're real. Are you actually, the person that's, am I Kevin Kettler, am I there? And it's got a little code on it, that code back, and we do the transmission back to usually the pharmacy benefit manager, who says, yep, that's Kevin. It's a $500 drug based on the NDC, the drug code. It's $500, and you need to collect $100 from Kevin. So that interaction, kind of like a credit card, Visa, MasterCard network, that's basically about 80% of the claims that do that in the country run over our network. So we're a network business. Now, the cool thing about that is what happens when that interaction happens. It happens like that, right? So microseconds, you don't have to wait for a week or two to figure out how much it costs. $100. Well, if I'm the manufacturer and I see this opportunity to get a $500 drug, that's $500 of mostly profit, probably costs $2, $3 to make the pharmaceutical. So I've got $490 to play with, right? So I want Kevin to get on that drug. So what do? Back to your affordability question. Well, I can make it more affordable, because I know that pretty good fallout at $100. Not many people are going to pay $100 for a drug. So we run what would be called a voucher program or copay program. There's lots of versions of this that say, okay, instead of $100, maybe for the first fill, I'm going to buy it down 75, and it's only going to be 25 bucks out of pocket. I'll pay 75, and I still make $400+ as a manufacturer. Again, this happens in real time, happens like that. Sometimes you know it. You'll have something printed on a leaflet. Sometimes you don't. But we facilitate about $10 billion of payments from our manufacturer partners to individual patients, probably some of you in this room, that get that kind of voucher. Now, we don't get all $10 billion. I wish we did. It's passed on to our patients, so we're in the business of helping patients get medicine. So that's really one of the, do a lot of things, but that's probably the biggest program we run on affordability.
And so how do you think about how the technology, you brought this up earlier in technology, how is it that technology will help you or the industry, McKesson, the industry, address the cost? We've been talking about affordability and we've been talking about access. So either one of those issues, given the sort of unique market that the healthcare space is in.
Yeah, I mean, I think go back to health. I'm sure there's some biopharma people who are more upstream who are in the business of creating cool new drugs. That's not me, right? Like, that's not our business. But I think there's a ton of technology to be put to bear to continue, the drug discovery process and the determination of efficacy and safety and all these things. Getting in the business of understanding the data and developing digital twins. And I think there's just a tremendous opportunity for developing, new innovation, new drugs, new delivery systems that I know nothing about that I think will have a material impact as we think about the future of healthcare. If I translate it more to like our world, I think it's more about solving the problems. And so I think about, I just shared some problems that are being solved at scale. I'll introduce another person. So the next person I'll talk about is a guy by the name of Rish. So Rish is a guy I met about a year and a half ago. Rish is a Stanford guy, of course. So I'm starting to have a type, aren't I? So Rish is on his fourth, I think, startup. He's probably 30-ish years old, kind of the prototypical, lives in San Francisco. So Rish's fourth startup is in health tech. Rish is like, I understand this AI thing pretty well. I'm a computer science typey guy. And boy, that prior authorization process stinks. Like, McKesson did a nice job, CoverMyMeds did a nice job of moving stuff around. But if I look at what happens in a provider office, it's horrific. You go into a large health system, I don't know if there's UNC health people, but it's probably 10, 20, 30, 40, 50 people who are sitting in some back office here or somewhere else that are doing those manual processes, probably on Epic, and they're going in and they're saying, okay, I need to prepare all the information for a prior authorization. Okay, I've got to go in. First, I've got to go find the patient record. I might stick on a sticky note. I might copy and paste. Maybe I have some robotic process automation. Most don't, but most of them go in. Then I've got to open up the lab records, and then I probably got to make a phone call down because that's not there. And then I've got to go make a determination based on, some complex history and sort through. Did they actually have that medication that they said was cheaper? So that's in the med history thing. So that might be in the pharmacy record. So what an absolute pain, right? So Rish says, that's not that hard. Like, that's what technology does all the time. It's especially now, we've got structured data, we've got unstructured data. So he creates a company that says, well, I can go actually make this much more easy. And so what his product does is it goes scrapes with AI tools and structured data and unstructured data. It knows, it actually pulls the clinical requirements to say, this drug is going to ask about, did you have this before? Are you male or female? Are you of a certain weight? What's your BMI? What's your lab results? Whatever that is, it goes and says, that's what you're going to be required. So Rish presents it now all to this person that doesn't have to go look it up in 10 different systems, but actually is the human in the loop. So it's still a human making a decision, but it takes the rudimentary tasks of going to all these places. So you have this large-scaled stuff that we do. And I think the next big iteration is going to come from the garages of Silicon Valley, right? So it's coming from the Rishes. It's probably coming from the people sitting in this room that are solving. Now there's so many tools and there's so much ability to take these complex problems that used to take, you got to go set up a server that, I can describe what a server is right after I talk about Y2K later. But these servers were these actual boxes, right? You just didn't go on and spin something up on Azure or AWS. So all these things that have been enabled all the way down to Chat GPT-5 and all this stuff that just didn't exist. And so the ability for these small companies to solve problems, I think, is going to be the next big unlock in healthcare. And I think that world is really just getting started.
So interesting that you bring that up, because we just had Jason Kylar, who is a Kenan-Flagler alum who founded Hulu. And you must be from the same brain in the sense that he actually made the same point. He was going through, what does it mean, like, what's the future look like? And he sort of said, if you want to understand, like, where to go, understand people's frustrations. And that's what I just heard you say, is there's a frustration. It's not about sort of that shiny object over there. Go look in the bowels of the back room, right, of where the frustrations are that everybody's hiding. And that's where you need to go to sort of unlock value.
Yeah, and I think the harder, the gnarlier the problem is, and the more unsolved it is, right, the riper it is. So I'll give you one more story.
That's good.
Riffing on random dudes. But now it's Cyrus. So Cyrus, he's a Wharton grad. See, not Stanford. I broke my type. So Cyrus decides that he looks at what we did, what the CoverMyMeds business did, of looking at prescriptions and understanding pharmacy benefit prescription and what it means to digitize the interaction between the PBM and the provider. And he says, wait a minute, it's actually much harder to do that for a specialty medication, so a complex therapy that's more costly. And I won't get into all the details, but you're either covered on the pharmacy benefit, that pharmacy benefit card, or it's a specialty benefit that's usually covered on your medical benefit. So you might have two cards, but that would be maybe a UNC Health or a United Health or somebody like that. And what Cyrus said is, I'm going to go do what CoverMyMeds did for the medical benefit. And I'm like, it's hard, right? Because first, there's no digital standard to determine whether or not your benefit is covered. There's no digital standard on the actual prior authorization. The number of processors that you have to interact with is like 50 times as much. Large PBMs, 3 of them control 80%, so you don't have the scale. And so what did he do? He actually took a job out of Wharton doing piecemeal work. I think he was getting $17 a prior authorization. So Wharton graduate starts doing prior authorizations literally in his dining room table to learn what happens with prior authorization. He wants to understand the problem so deeply that he's like, the way I understand it is I actually go do the thing that is the problem. So he does this for like 6 months a year and starts building a company. We bought his company about 6 months ago. So.
I think as an educator, that is a great story. And the reason I say that is, when students say, why do I have to go? So I'm an accountant by training, as you know.
I do.
And, why do I have to go do the debits and credits, those awful words that people talk about in accounting?
Debit's still on the left and credit's still on the right?
Depends on which one. No, I'm just kidding. I'm kidding. But, it's that is, there's a fear in education and academics and I was actually just having this conversation earlier about how is it when these tools can do all this and everybody wants to be glorified up here only doing this, but if these tools are making mistakes, who's going to sort of understand the tools, and how are we going to educate people so that they understand how the AI tools, when they're going well and when they're not? And, in healthcare, that's huge, because on the other end of it is potentially somebody's life, right? And I think about, as you said that, I'm like, the use of AI and technology in a space like this, how do you ensure your people, as well as the technologies that are evolving, get it right?
Yeah, I mean, I think you have to start with the premise that people don't always get it right. So I think, one of the challenges we have, I think it's true in healthcare, true in everywhere else, is we're starting to hold a higher threshold to newer processes that are more digitally enabled than we would have ever held our, legacy individuals. So I think you have to start with a real pragmatic view of the fact that we have to make sure that we're comfortable with some failure. Second, I think for anything, certainly early on, understanding that you have to have a human in the loop on most things. Now, I mean, we're not far enough along on kind of our digital transformation to say that you can never let the machine go, right? I mean, we certainly do, automated processes using AI that pull in information to, make it easier. But it's mostly rudimentary tasks, not decision, right? So you're not, it's not more Gen AI, it's much more kind of AI of translation.
Right.
And we're using, processes that do validations and, do checks. So I think it will be interesting, I don't think we've really gotten to let the machines loose yet. So it will be interesting to see how comfortable we get. Have you driven in a Waymo? Right? Like
No.
No? Anybody? It's awesome, right? Like
What's a Waymo?
it's a car.
Well, that's
with
what I
no
got
driver.
that from the driving.
Yeah, it's a driverless
Can you
car.
tell we go way back?
It's an autonomous vehicle. So
okay. Yeah.
Yeah.
They don't have that in my neck of the woods.
Woods being the key word.
Yeah, woods being the key.
So, like 10 years ago, would you say you're going to feel completely comfortable in a driverless car? I'm like, probably not.
Yeah,
I feel
right.
totally comfortable in a driverless car. So I think the point is, if you take that same translation, I think we as a society will get more comfortable. I think the stats would tell you the driverless car is a much better driver than or much better safety record than a person. But many people would not necessarily embrace that, even though the stats tell you differently. So I think over time, we will get to the driverless car, right? We'll allow the decision-making, we'll get comfortable with the decision-making on certain things, probably not on everything.
Yeah. It's interesting because, it's to some degree it's about trust, right? And trust comes from two places to some degree. The interpersonal relationship, trusting someone, right? And that can come through in a variety of ways, or experience with the thing or the person, right? So what I hear you saying is that trust is being built through the experience of it, right? But there's also times where you have disruption where people don't have enough reps and experience, and the trust is actually born through the humans, right? That sort of humans trust humans before they trust, maybe on average, before they trust machines. And that just sort of lends itself to, because one of the things is, with tech, I think what's the different is when there's a mistake, though, it's a mistake on scale. When I make a mistake, maybe it's more individualized, but if we have an algorithm that has an embedded mistake in there, there is potential for a path at scale that is not a good outcome. And so that lends itself to, if you think about policies, I mean, you're in an industry that's already regulated, right? And here comes this force, these technology forces that aren't regulated, and there's so much potential for them with opportunities, but also risk. And how do you think about policy intervention? I'll sort of break it down. You can pick one or both. Is in the AI side or the tech side, and or the healthcare side, or the intersection of those two. Because there is stuff that's coming down the pipeline, and you would think the government would be more engaged in the effects of tech because it's in the healthcare industry.
Yeah, so I agree with that. So
Okay.
I agree that I think the regulators view their role as one of protection in here and trying to figure out, given the scale impacts and the human impacts of healthcare and health tech, that they're kind of appropriately starting to wade into it. I think the challenge is actually the same for the government as it is yesterday, the day before. We had a long discussion on our commercial contracting, and we are trying to figure out now. There's broad government guidelines on kind of appropriate use of AI, but there's practical uses of within certain products, within certain data sets, like can you train your models on the data that you're using your services for? And I would say nobody really knows what anybody's going to do really with a lot of definity or the broad strokes. So it's a dance right now, right? Of like, you don't want to be too restrictive because ultimately you're providing value and innovation, and yet at the same time you don't want to let the whole thing go and then either lose value if you're one of the constituents providing data that trains the AI model, or lose, quality or control. So I think it's going to be this, I'll just use the AI or the driverless car example, right? So in Phoenix, whatever, 6 years ago, a woman was unfortunately, I think, hit and killed. I think that set back the driverless car industry appropriately so, because it had gotten ahead of itself. So I think there's going to be, hopefully not at that level, but these kind of back and forth trade-offs as we go through of like, how do you appropriately use AI? There'll be some probably notable things that will stick out on the downside, and it will kind of move us back, both regulatory-wise, policy-wise, and commercially.
Well, that, to me, that's when you think about disruption, right? That's what disruption, it's not stable, like it's not linear. All this technology, the constant disruption comes from the moving forward, making a mistake, the navigating. It also comes from interventions from policy. So you've been in an industry that has both been disrupted by macro events, policy events, technology events. People sort of out there and thinking about constant disruption, I'm going to tie to leadership right now, because I'm really curious, given your experiences, how do you think about leading an organization in the midst of disruption?
Yeah, I think it starts with solving problems the right way, right? So I think you're going to always have things, macro events, policy decisions that happen, and I think if you can root the aspects of what you do, and we root ours on the patient. And our job in healthcare is to basically help patients get access and afford the medicine they need. So we're not in some nefarious activities of trying to not support something of good. And I think if you start with good principles, and the second thing is we have a strong set of kind of operating principles that we do things the right way. So I think if you do those things, I think it actually helps you be well positioned for when those things happen, and they do happen, is to actually then be prepared and ultimately be better than your competitors in being able to weather those. The last thing I would say is the strategy of the business is incredibly important. And so how well we continue to look out and scan the environment and understand what are the next things. And we're making decisions about the businesses we're in. I'll use an example probably related to policy. If you think about the Inflation Reduction Act, right, the IRA, one of the things it does is it really pushes for use of more specialty medications, because it includes what the vernacular is the pill penalty. So less complex drugs are going to be negotiated sooner than more complex drugs by the US government. And so what does everybody do? You have a longer time frame with more complex drugs, or rare and orphan disease aren't as subject to price controls or price negotiation. So what do? Well, we start buying things like Cyrus's company, because we know that the complex medications are going to be more prevalent. And so kind of connecting those dots of, okay, so you educate policymakers, you make sure you do things the right way, and you skate where the puck's going to be. You look around corners, you start identifying trends early enough where you can lay down tracks that may not make a lot of money today, but we know over time that that's more likely to have a positive impact than what we're doing today.
Yeah, it's interesting because you're constantly, I think about higher ed, right? They haven't constantly had inflections and things coming in. They are now. And so,
maybe you guys should have quarterly earnings reports where you have to actually go defend and long-range plans and investor days. That would probably be
but they're having, it's moved, right? And but I think healthcare is a great place to look, because it's an industry that is highly regulated. I would argue higher ed's highly regulated too. But it's been under constant disruption, and watching how watching how different parts of the healthcare space have dealt with that. Might be lessons learned for higher ed. I don't know if there's anything with regards to, I also think about, as we talk about regulation, there's so much policy coming through. How do you, when you're leading a company in the healthcare space, think about how you stay ahead? Knowing that a lot of the stuff coming around the corner is coming from the policy arena.
Well, I think it starts with education. I spent a lot of my time with our strategy team, a lot of time with policy, our public policy team. I was actually supposed to go last month to meet with Chris Klump, who's the head of CMS. Got canceled because the government shut down. I've met with him before. So it's out, interacting with those folks that may have influence on these things that may have impact on your business. So it's part of your job as a leader in a company is to make sure you actually understand what are those potential threats, but they're also the areas of potential opportunity. So you're out there not only kind of understanding what they're potentially doing to you, but you're understanding what are their initiatives. And so, take the work that we're doing with the government. They've implemented and have an aspiration to digitize electronic prior authorizations. So, we're super aligned to do that. And in my view, there's nobody better. And so we can go help facilitate interactions with the government that says, okay, we know you want to do it. Well, let's start with what works today, and let's educate you on what we're doing so that then as we think about what standards you want to put in place, we've got NCPDP, which is a standard transmission. Let's make sure we include that as we think about the standards going forward. So it's those kind of things where you're out making those types of kind of interactions. And then you also sometimes have to make tough decisions. So we're in a process. Actually, does anybody listen to the Acquired podcast? Yeah. So the one on Google about 2 or 3 weeks ago, maybe it's older than that, but it was awesome. But one of the things it talks about is this transition that Google's going to have to make to its kind of legacy ad-based, it's probably I think they describe it as the best business model like ever created in the world, which is probably right. But it is going away, right? I think Google search for the first time a couple of months ago was down because people are going to, any of the AI tools, any large language models, and getting the information somewhere else. So you don't have to go search it there. So anyhow, they're making a transition to say, well, they're starting to kind of like just put a little bit of Gemini in here and there. They don't want to totally ruin their search results. But you can imagine sitting in the boardroom and going, wait, you're going to go give the answers and you're not going to have search and we're not going to be able to monetize all these eyeballs that we made $1 gazillion on? Like, you can't do that. So we have a little bit of the same conundrum. We would like to go disrupt the prior authorization concept because ultimately it's kind of broken, right? We talk about all those people in the back room and all the processes. Shouldn't we just know whether or not Kevin should be able to get on the drug because I have a bunch of information on him, I know what the coverage is, I know he's actually going to do it or not do it. So I think this kind of idea of disrupt thyself and what's the strategy that's going to get you ahead of pressure. If you can continue to stay ahead of the areas where you know the pressure is going to come, it actually future-proofs even if you have to iterate and kind of kill yourself. I think the Google thing will be fascinating to watch over the next year or two.
Well, it's interesting because as you've been talking, I've been thinking about all the uproar over electronic medical records. But think about it, and how everybody complained about that year, including my husband, who had to, as a private practitioner, do electronic medical records. It was the bane of our family existence for many years. But yet, we can't do the things with the technology tools today if we don't have the data. And if we didn't have electronic medical records from years ago, we wouldn't be along the pipeline in the data. So what is the cost, to your point, what is the cost today and feels awful today, right? Because it's hard or it's painful, or it's whatever, actually ends up being the opportunity 10, 15 years from now. So how do we recognize potentially whatever we're complaining about today actually could be the thing that creates the opportunity in the future?
Totally, and I think for those of you who are familiar with the 21st Century Cures Act and TEFCA and Qualified Health Information Networks, it's going to be fascinating. So this is just a data unlock that the government has kind of started to put in place. If you don't know about it, go check it out. It's one that we're watching that I think it's part of the requirement now is to kind of allow for this data liquidity, and you think about what's going to power the future of innovation is data. And so this is, to me, a fascinating area to kind of see how it unfolds.
So I have one quick question before we close for questions.
Mhm.
In the sense of, we've been very U.S. focused, right? And you have lots, sorry, should you do this? You have lots, because you've been gone a long time. I haven't seen him in forever because he's been overseas. And I'm curious, does that experience, overseas, as you worked with European countries, has it affected how you think about what you're doing now, the issues you're facing? Because we can get very U.S.-centric, and when we're in different places, we see the way different governments handle things, how they engage with technology. I don't know. I just was curious if it's provided you any insights.
Yeah, well, first it's given me a lot of great places to go on vacation. So that's probably the number one thing it did. But I would say on the more the business side, the macro difference, if I think about most of the countries, it was all Western Europe, and most of the countries, it all had some sort of nationalized, if not complete nationalized healthcare, right? So do I have time for one more story?
Yes.
Okay, quick one. So this is the last quick story. So I've got twin daughters. One's Quinn. Quinn, awesome athlete, but a little bit injury prone. We're on vacation 4 or 5 years ago, running across a field with her cousins, breaks her toe. We're flying back to London the next day, so I have to take her in, get x-rays. I have a choice. I can take her to the NHS, or I can take her to private healthcare in the UK. So long story short, I'll be quick. Take her in, and they say, oh, great, welcome Quinn in, credit card, 100 pounds, okay? Quinn needs to get an x-ray, credit card, 200 pounds. Okay, Quinn needs a boot. I'm like, does this one work on Amazon? They're like, yep, that's good. So I'm out for, call it 400 pounds. Quinn, unfortunately, about 2 years later, breaks her other toe, other foot. This time we're in California. We're up on vacation in the summertime. She actually jumps off a rope in a pool and hits it on the knot, whatever. So I take Quinn to the emergency room, covered on insurance. We have U.S. and international insurance, but we're covered on insurance. And lo and behold, we get like this, $2,000 bill, right? Copay $100, right? Then we get another bill for the x-ray, which is like $400. Copay is like $100. And then we get a consulting fee, was like $100 for reading the x-ray, I think. And then we get a boot that was like $150. So the net of the whole thing is we paid basically the same amount out of pocket for covered insurance, of which the ecosystem paid about $3,000 or $4,000. We paid $500, and we paid $500 in cash in the UK, or we could have done none in the UK. And so I give that example because now that's a great example, and we had a long discussion. I did a similar thing with this a class, and I said, which would you rather be in, right? So what's the implication of being in those systems? And a bunch of people are like, well, do the UK, it's just easier. And then the question is, well, what if Quinn had, unfortunately, a rare disease or some medical condition that required a lot of cost? Well, it's still $100 and it's still $200, and maybe you don't even get access to it. And if you do get access to it, it's going to take 3 or 4 years. So it's the trade-offs. I don't think there's a perfect system, but I think the macro trade-off is cost and access. And I think when you're more controlled and more reliant on the government's decision around those things, you have less freedom. It may cost us more, but we have more freedom, and we ultimately have more access to life-saving medications. We have more access to make decisions. We have faster access to care generally. So it's a trade-off.
I appreciate that. Thank you. Perspective.
Sorry,
No, that's good. No, I think it's important because there are different experiments running around the world, and there's no one right answer. It's sort of, what do we learn from each one?
Yeah,
right.
That's
I appreciate
right.
that. So let's take questions. There we go.
Hello? Yeah. Thank you for the wonderful keynote. My question is just to kind of keep the theme of disruption. I know that CoverMyMeds and McKesson broadly has a very close relationship with the PBMs and the pharmacy benefit managers. I'm curious what your opinions are on potential disruptions moving forward to the PBM industry as a whole, which I'm sure many of the colleagues here can probably attest that could be considered an extractive industry, to say the least.
So I will say I'm of two minds. And I don't know if you have an opinion on PBMs, but I'll give my, yeah, okay, I'll take this one. So if you look at the history of PBMs, they have done an amazing job of continuing to innovate. I don't think there's been as large a scale industry that has pivoted how they've made basically pools of profit over the last 20 years than PBMs. Right? It used to be a generic spread model. It used to be then a mail order business, and then it was really about specialty, and now it's about offshore GPOs. And so they've I think, provided some benefit in the form of driving towards a formulary to get concessions from manufacturers to pass on patients, and they've profited handsomely by the lack of transparency that happens in the market. Now, this is probably the 6th time in my career that they've claimed, but now it's different. We're actually being more transparent. It used to be rebates, and now we're going to pass on the rebates. So I would say, I don't know, but I think there is the government pressure, and I think some of the stated intentions. So the latest is they're now going to be very price transparent. So they're actually going to pass on the prices, and they're going to take the rebates that they were getting and actually put them up front, so that if that $500 drug that you were paying $100 for, if your PBM got a $200 rebate, that may be passed on to you, or a $100 rebate, it would be free for you, right? Or you'd see that in the cost of the drug. So I think the general direction of travel is the right one. I'm skeptical that, given the ecosystem that we talked about that lacks transparency, where they're a scale player, that they're going to be significantly pressured in a way that changes. So, does anybody in here work for a PBM that wants to?
Other questions? There's one right here.
Hello. I was just thinking about, as we're incorporating more technology into healthcare, how are companies thinking about protecting their patients' information, but also protecting the company and making sure that they're not having to handle large security breaches?
It's a great question. So one, I think there is a good, and I would argue maybe overly restrictive codification through HIPAA and the requirements that, for those people who are in the room or who are deep in the healthcare system, it's a pretty onerous process to appropriately manage data for individuals. So I feel very comfortable as an individual with my health data out there floating around, that the restrictions that I know that our organization has to comply with in order to protect your data in the room, to make sure that it's only being used for the appropriate purpose. I think there's tons of kind of appropriate and maybe even overly restrictive ways that happens. On your second question, now, with the exception of, if I get to the point, my earlier comment of the garage in Silicon Valley, they're going to innovate faster. They're going to be more loose, right? I mean, it's one of the toughest things we have when we look at acquisitions or partnerships is our threshold is here, and most companies are here. So that would be the risk in that, is the lack of sophistication that comes with these kind of new, nimble folks. They have to really advance that. To your second question, I think it's true across which is cybersecurity. We go to great pains, and I know many organizations throughout healthcare. It used to be 5-6 years ago, healthcare, there was kind of a hands-off approach for cyber criminals to healthcare data. That changed about 2 or 3 years ago. You've seen health systems, large health systems get hacked. Change Healthcare, who's a competitor of ours, got hacked about 1.5 years ago. Now, the good news is that those impetuses have put more requirements and more investment in companies like mine to make sure that we're doing the best we can. And the reality is, you can't be perfect at it. And so, today, tomorrow, next week, anybody can get hacked. I think the two questions are, for large infrastructure, what are you doing to prevent it? And two, what are you doing to stand up an ability to recover? In the case of Change Healthcare, we had a bunch of people who couldn't collect their bills, patients that couldn't get their medical records. So how do you actually recover fast enough?
I think that the points you make is life is about risk, right? And are we thinking about them appropriately, and which ones do we take? And if you beat up somebody who's taken appropriate risk, we've got to recognize in this world, you can't move forward without taking risks. So the question is, as a leader, how are you thinking about it, guarding against it, knowing that it will never be perfect? I think that's a really important business lesson that, because at business, that's all we talk about, right, is risk and return. And I think one of the things is, I'm just picking up on this because it's such a big deal to understand that you can eliminate risk. It's just, for a business to move forward, you cannot eliminate risk. So I appreciate you saying that.
Well, not only can you not eliminate it, most of my job and the chair that I sit in is risk management.
Yeah.
People leadership and risk management. If you really boil it down, like you're just making
summary.
You're making calls on strategy, people, and risk. So how do you reposition the business for growth? What are the things that come through that people want to do, or you think should be done, or are being done but may not? So I mean, that's how much we could spend all of our time trying to eliminate risk. And the reality is just not practical. So what are the implications and what decisions you have to make in spite of that risk is really where the leadership comes.
So let's say you were, I'm going to close this with this. So let's say you were czar of healthcare. And you are now looking out to the next 10 years. Okay. What do you think the industry is going to look like? That is a big question. So I'm making you czar. More centralized? Is it fragmented? Is it?
I think it's more personal. Like if I were to pick a word, if I think about some of the things that are happening on both the innovation of drugs, on the actual information and the ability to kind of make decisions, right? I think about even now, getting bots or, AI agents that can go out and determine certain things for me in my job. Like, I translate that, I'm like, well, because it's starting to get to know me and it's starting to get to write emails the way that I write the emails or, deconstruct things the way that I understand it. Like, I see no way that doesn't get reflected in healthcare, where all of a sudden it's going to be smarter, it's going to be able to go across all these things, going to be faster, and it's just going to be much more capable of being about me. And so I think that's the one big thing that'll change.
Okay, so I'm going to just add on to that for just a second. So I get it. You say personal's the word when you look out. But as a leader, you said, there are things that you have to think about, risk. So if that's the word, if it's personal, right? If the healthcare system and the one where it's personal, what's the risk associated with it being more personal?
Well, the risk for my business? Yeah. Well, we operate large-scale businesses that are, by definition, kind of treating things ubiquitously, right? A standard way that we interact across things. I talked about the, prescription adjudication process. Right. We do that not each individually, do it one way. And so I think the risk that all of us kind of embedded large-scale players, you're going to be a railroad company and somebody's going to invent a car to move you from point A to point B. It's tough to go undo a railroad, right? Like, so I think, or turn the big ship or whatever the euphemism is. So I think it's understanding where those disruptions are going to happen and how do you move fast enough to be part of it and not get stuck in the way that you used to do it. That's less personal, maybe, to use the exact analogy. So I don't know what that looks like, and I wouldn't say we've kind of charted that on our worry wall of how we're shaping our strategy, but that would be the implications, I think, as I think about it.
Interesting. Okay. No, it's interesting. Thank you so much. Can we give Kevin a hand? Thank you. So I'm humbled in the sense that, so I went into tax because I thought it was the most complicated discipline
I think it is.
out there. And sitting with you for this time, I am like, nope, I think it's healthcare. And the commands you have, I think that's the other thing that, if I think about as I hear you talk, and I think about sort of the students in the room who are here as you talk, is the command you have, not just over your space, but the industry at large and how to think about it. I mean, really understanding. I think you told me something a couple weeks ago. Uh-oh. Yeah, uh-oh. And I have used you, I've quoted you, okay? We talked about sort of Kevin and, how he moved through his career, how he made choices. And what he said, and I'm seeing it now, is Kevin said, look, I got some advice. I don't know if it was from Paul, Cyrus, or whichever person it was, but you can correct me because I'm not going to get it right. Get up in the morning, come to your job, do your job, do it well. Show up and do your job well. And I think what I see, and you said you took that advice, that's just how you've lived your life. You show up and you do your job well. Well, what I can see as we were having this conversation is if you show up and you do your job well, you're constantly learning and it's accumulating in a way that you have a vast understanding from each place you've gone, so that as you continue to move, you're collecting more and more as you do your job well each day. And the command that you have over this complicated industry is just quite remarkable. So thank you for joining us. I really appreciate it.
Well, that's awfully nice. If I could leave you all with one thing, which is the takeaway from this is it's super fun. Yes. Right? It's fun because it's really hard. Yeah. And it's fun because it takes the type of people that are sitting in this room and that go through this school and that are educated in this way to be curious, to solve problems, to drive leadership in an organization that isn't always clear, in an industry that isn't always clear. And so I didn't necessarily come sit in the halls here, or actually Carroll Hall, and be like, I'm going to be a healthcare person, but I kind of got the bug, and I hope that you all got a little bit of maybe a taste or a bug of what it is for somebody who's been around it too long, that really appreciates what the opportunity is, both personally, but also what the opportunity is to have impact on people. So,
well, thank you for coming back and sharing.
Yeah, appreciate it. My pleasure.